who is Professor of Health Policy and Management in the Department of Health Promotion and Policy. Her research in health policy addresses tobacco control, electronic cigarettes, diet, physical activity, and management of long-term conditions. In addition, she's passionate about communicating complex information and data to inform public action, and works hard to engage the public in her research. And to that end has been involved in podcasts, blogging, TV and radio interviews, and news to me, songwriting. So this is something to look forward to for some future, maybe spin on the Dean's Seminar series, the Dean's Concert series, to communicate her research results outside of academia. As a non-academic tidbit, Jamie grew up in the area here in New England, but has been abroad in England for more than a decade and returned to the area this summer with her young family. And other than difficulties getting her dog into the country, which worked out in the end, the transition has gone very smoothly, and we're really pleased to have her join us today to give seminars. So please welcome Dr. Hartmann Boyce, and I'll hand it over to you.
Thank you so much, Brian, and thanks all of you for being here today. I'm going to share my screen. Let's see. I'm going to go into slideshow mode. So hopefully you can all see that. What I can't see is like half of the room, so I'm going to move so I can look at you guys. That seems a little bit better. So awesome. Thank you so much for being here today. I want to talk about some research I've done looking at direct and indirect risks of COVID-19 in people with diabetes. The work that I'm covering today was funded by the World Health Organization and the National Institute for Health Research, which is kind of like the NIH, but in England. I don't have any conflicts of interest to declare, but I want to acknowledge that all of the work I'm presenting today was done as part of a big team. So massive thanks to all the people who contributed, and that includes people at the organizations of the World Health Organization and Diabetes UK, colleagues of mine at Oxford, a bunch of undergraduate students who helped out on a lot of this research, colleagues elsewhere all over the world, and over 60 people with lived experience of diabetes. What I'll cover today is I'll start with a little bit about me, a little bit about my general approach to research, and then cover what in hindsight looks like a program of work to have to do with COVID and diabetes. In reality at the time, it was like one thing, and then we're like, let's do another thing, and then we're like, let's do another thing. So it didn't start off as a program, but it kind of became one. So I started my education here at UMass at the UMass daycare. My dad was a UMass professor until he retired, so it's really nice to be back here, but it was a pretty meandering path to get here. When I was a student and an undergraduate, my love was the arts and English literature, so I was an English literature major at Tufts, but always had a particular interest in healthcare, and that stemmed, I'd say, mainly from my experience of living with type 1 diabetes. So a lot of what I'm presenting today is personal to me as well. And when I graduated from college, I wanted to access insulin, and I decided one way to do that would be to move to a country with national healthcare. So I moved over to England. I worked in medical publishing for a while. I got my master's there part-time in the history of medicine. And that picture there behind me is of a bunch of tobacco industry executives swearing blind that they had no idea smoking caused disease when they definitely did. And that's what I focused on in my master's work. It was all about the role of the tobacco industry and its influence on US healthcare policy, mainly in the 50s and 60s. I then ended up working with a group called the Cochrane Tobacco Addiction Group at the University of Oxford. And Cochrane is a nonprofit that does massive, extensive, systematic reviews in all different sorts of areas. I got into that in a publishing role, and then I kind of realized I wanted to do the reviews myself, and was supported there to do a PhD, which stemmed from work I'd done with NICE, which is the National Institute for Health and Care Excellence in the UK. It's the UK guideline developers. And the work we'd done for them looked at lifestyle weight management programs, as they called them. And so my DPhil kind of explored that a little bit more, then moved on to the Center for Evidence-Based Medicine at Oxford and landed here in September. I'm really, really happy to be here. But I think that path kind of helps illuminate some of why the next step I did, I felt like doing. In the end, the reason why I do research, I kind of didn't go into academia thinking I love research for research's sake. I did it because I felt like I wanted a job that felt meaningful and was going to benefit people's health. And because I trained in something called evidence-based medicine or evidence-based healthcare methods, I tend to follow a pretty formulaic approach when it comes to doing what I'm doing. What that means is I always try and start with an applied healthcare question that isn't just something that pops into my head, but is defined with policymakers, service users, and service providers. And where the evidence-based healthcare comes in is that then what I do is I try and figure out, okay, what's the best available method to answer that particular question? And for me, that often is something called evidence synthesis or systematic reviews, which means we bring together all of the existing evidence on a topic. We see what it says overall, and we also make judgments about how much we can trust that evidence. And together, time and time again, that has led to meaningful research that has informed policy and practice, which is always a good reason to get out of bed in the morning. So the research questions I'm going to come on to cover today are the following. The first is, what is the risks of SARS-CoV-2 to people with diabetes? How have disruptions caused by the pandemic affected outcomes in people with diabetes? And how will disruptions caused by the pandemic affect outcomes in people with diabetes for years to come? And the reasons why we set out to answer these questions are multifaceted. We knew going into the pandemic that people with diabetes are at higher risks from infections generally. We're one of the groups, for example, who's always really, really strongly suggested to get our flu shots. It was expected that the same would be the case for COVID, but we didn't really know when the pandemic started. And it was really important to get a sense of this in order to, for example, prioritize who is getting vaccines, understand who needs to take more preventative measures. And even now it feeds into, for example, whether or not you end up getting prescribed Paxlovid if you get COVID. I had COVID a few weeks ago and I had Paxlovid. So this is really important research. We also know that not only are people at direct risk from infections, but there are also indirect risks. And what we mean by that is beyond being infected ourselves, what does it mean to have these disruptions going on? A lot of people will have experienced limited healthcare access during the pandemic. And when we look at evidence from previous events that have disrupted healthcare, we see that people with diabetes tend to fare not super well. And one of the interesting things about diabetes is you can have short-term consequences of that, but you can also have long-term consequences. So if you have a period where your blood sugars are, let's say, higher than they would normally be, that might be okay for the next year, but 10 years from now, you might suffer increased complications because of that. There was some evidence that in terms of previous disruptions, this was worse for some groups than others. This is as much as we would expect. It tended to be people who had more difficulty accessing healthcare. Women tended to fare particularly badly in the evidence we saw, and people who needed insulin tended to fare particularly badly. And then the pandemic came along, and we needed information, and we needed it really fast. And what I remember hearing at the time, I was listening to the radio, and someone said, oh, it's so great because with COVID, it's a great leveler. We're all in the same boat for once. And someone else called in and said, same ocean, but very different boat. And I think that's a good metaphor that kind of guided a lot of what we did here when we thought about, yes, we're all living through this pandemic, but we all have very different vulnerabilities and very different levels of privilege that help us access healthcare or stop us from accessing it during the pandemic. So when I was at Oxford and the pandemic kicked off, we launched something pretty quickly called the Oxford COVID-19 Evidence Service. And the idea here was that a lot of people at Oxford in my group had experience of doing systematic reviews. So we had experience of going out, finding evidence. We knew how to find it. We knew how to judge whether or not to trust it. It seemed like this was a really relevant thing to be doing. And instead of us coming up with the questions, we basically had a Google link to a spreadsheet. And we had doctors, policymakers, people in communities putting in questions, and then we'd pick which ones we were going to answer. Before this came along, I'd never done any research into diabetes deliberately, because if you live with type 1 diabetes, you basically have to think about it all the time. The idea of thinking about it even more didn't particularly appeal. But I was thinking about it a lot. I was reviewing the evidence for myself, and I thought, you know what? People are now asking questions on this service. I'm going to get involved in answering them. And so we did a few rapid reviews looking at the evidence that we had so far, which tended to be pretty minimal at this point because we're in April and the pandemic really didn't even get acknowledged as a thing in England until March of that year. But in a kind of amazing turn of events, doing this work generated interest internationally because I think no one else was writing about this at the time. And what will remain always the quickest thing I've ever written and gotten published followed on from that, which was an article on risks and management considerations, which we submitted in May and got published in May in a journal called Diabetes Care. And that was a really interesting thing to get thrown into. Someone from the UK got involved who had a real international network of people who were kind of leading diabetes policy. And so what he did is he went out to these people who were in charge of essentially diabetes services in their countries and asked them what was going on during the pandemic and how they were planning to deliver diabetes care. And so we integrated that into this review, which wasn't a systematic review, but came out with considerations for how we might manage diabetes in the context of national emergencies, which included what you might prioritize in terms of contact with healthcare professionals where services were restricted, what you might do in communities, and how you might support patients throughout. And one of the ways you can tell this was published really quickly is that they didn't redraw the graphic. And so that's the picture that went into this journal article. So that was kind of a launch into this space. And we got a lot of feedback on it quickly. And it felt like it was important to keep doing it, but we didn't quite know what to do. And then in December of that year, we were approached by the World Health Organization. And what they do on relevant topics for their member states is commission people to produce what they call rapid reviews and scientific briefs. These follow a really specific format. They tend to be short and to the point, and they're basically a way for WHO to put out evidence on emerging things quickly, although not all that quick because it goes through a lot of approvals. But they'll go out to academics and say, will you do this for us? And they pay you an amount of money that does in no way cover the amount of work you're doing, but it feels like a worthwhile and interesting thing to do. So many of us do it. That ended up in us publishing in September of 2021 an overview of reviews of the risks from SARS-CoV-2 in people with diabetes. And it's just struck me, I wonder if I can make that small. Yeah, then you can see more of my slides. So this is this paper, and this is quite astounding, really, in that we searched for evidence up to summer of 2021, and we found so many systematic reviews had been published already that we didn't even need to do a review of primary studies. So COVID had been around for about a year and a half at that point, and there are already 112 systematic reviews of varying and mainly poor quality for us to go through and sift through. And what data consistently showed was that diabetes increased the risk of severe COVID-19, including things like ICU admission, long-term effects, and mortality. Type 1 was associated with worse outcomes than type 2 diabetes. Higher blood glucose or blood sugar during and prior to infection was also associated with worse outcomes. And one of the things that we tried to flag here, which very few of the studies or reviews looked at, was that as both diabetes and COVID-19 outcomes are associated with socioeconomic disadvantage, there's probably a pretty significant interaction happening here. One of the problems with COVID was that we had so much data and so much of it was pretty rubbish, right? So a lot of these studies wouldn't even drill down in terms of the type of diabetes people had, let alone people's race, ethnicity, living situation, etc. So we had kind of these single variables floating around that we were dealing with. And it felt like we knew there were bigger problems under the surface of these data that we just couldn't get to at the time. So one of the things that also struck us during this is we tried to keep conversations ongoing with people living with diabetes. I was obviously one of those people, but I don't think I'm super representative in that I understood this research really well. I understood how to navigate the healthcare system really well. And we knew that a lot of people would be having different experiences. And in all the work we do, we try and reach out to people with lived experience. And often, not always, but often it can be quite short conversations, right? People say, yeah, I think you should do that research. That sounds great. Don't really have much more to say. We were spending hours on the phone with people who were talking to us about what it was like to live through this pandemic being labeled as someone who is vulnerable, worrying about accessing healthcare, worrying about routines being disrupted. And that made us think even more about the importance of trying to do something to look at what the pandemic itself had done in terms of diabetes outcomes. And so with a little bit of funding from the National Institute for Health Research in May of 2022, we did a quite restricted systematic review, including a meta-analysis, which is what happens when we combine the results of studies statistically, to look at the impact of the pandemic on glycemic control, in other words, on blood sugar levels in people living with diabetes. That had data from 59 studies, so much data came out during COVID. It was really hard to keep a handle on all of it. And somewhat to our surprise, although when we thought about it more, it was less surprising, we found the pandemic was actually associated with improvements across multiple outcomes of blood sugar measures. It was unclear whether or not that was clinically significant. The measure that we use in diabetes of long-term blood sugar control is something called HbA1c, and the changes we were seeing were small, but they were in the right direction. However, almost all the evidence in this review came from people with access to diabetes technologies in high-income countries. And so we concluded from that more research was needed in less advantaged populations. And just to give you an example, this looks at HbA1c, so that measure of long-term blood sugar control, before and during lockdown in people living with type 1 diabetes. And this is a forest plot. So each of these rows represents an individual study and the change in HbA1c before compared to during lockdown. And in almost all those studies, what you see is that HbA1c is lower during compared to before lockdown. So it looks pretty consistent, except for one very clear outlier, which is that study right there, Burma 2020, where we see HbA1c going up quite a significant amount during the pandemic. And when we looked into that paper more, we found that the reason was a lot of the people in that study were struggling to access insulin during the pandemic. Amazingly, they still had their HbA1c readings done. But what we know is probably most people who struggled to access insulin also struggled to have their HbA1c and their lab tests done. So this is such a highly selected population in these studies. And this is just another example. Time in range is a way that we measure our kind of daily blood sugar control via a continuous glucose monitor. And basically, the higher your time in range, the better, because it means you're sitting within your targets. In all of these studies, we see improvements in time in range. So it's easy to say, oh, good, lockdown was great. And for many of us, it was. It's much easier to remember to take your insulin and monitor yourself when you're not also running to get to work and get your kids to school. But the proportion of people living with type 1 diabetes who has access to this particular technology is really, really small. So again, we felt acutely the limitations of the published evidence in this sense. The people that we think are going to be most adversely affected by the pandemic don't have data, and those things are closely connected. So following on from that, we had a few more conversations with the WHO saying, please, will you let us look at indirect impacts more broadly? Will you fund us to do this? And they said yes, as long as you update that existing review as well. We agreed to do that, and in October of this year, published an update, which unbelievably found in the last year another 116 systematic reviews looking at whether or not people with diabetes were at higher risk from COVID. And unsurprisingly, they still are. One of the painful things when you do systematic reviews is you see a lot of research waste. So it takes a lot of work to do studies. It takes a lot of work to do reviews, and to do the same review over and over and over again, finding the same thing over and over and over again doesn't seem the best use of researchers' time or funders' money. And yet here we are. So that brought our total to 228 systematic reviews, which all were very consistent in terms of risks of severe COVID. There was some evidence that the difference between type 1 and type 2 wasn't as clear. There was some conflicting evidence about a specific drug for type 2 diabetes and whether or not that led to worse outcomes. And there was pretty clear evidence that people with diabetes who used insulin were at greater risk of worse outcomes than people who didn't use insulin. And that's not a massive surprise. There are a few reasons why that might be the case. One is that if you have type 1 diabetes, you use insulin. So type 1 diabetes is where your immune system attacks your insulin producing cells and you need to take insulin. Type 2 diabetes is a disease of insulin resistance. And a lot of people with type 2 diabetes don't need to take insulin, but if all other medications have failed, they might go on to insulin. So you're getting a selected population there. Also, unlike some of the other diabetes medications, it is hard to go a day without insulin if you need insulin, right? You go down south pretty fast. And we know that COVID makes people insulin resistant. And also, especially at the start of the pandemic where we didn't have antivirals, a lot of people with worse cases of COVID were being treated with steroids, and steroids and insulin are not a beautiful combination. So lots of reasons to suspect that that's reflecting an underlying truth. But what I want to spend the rest of my time talking about is our review looking at the indirect impacts of the pandemic. This hasn't been published yet, so it's still somewhat subject to change, but it has now been accepted and is in press. So unless the copy editors find something awful with it, I think the conclusions are there. And what we set out to do here was systematically review available literature on the impacts of disruptions caused by COVID-19 in clinical outcomes in people with diabetes. And this is wordy, but this couldn't be solely attributable to COVID infection. So this couldn't overlap with our previous review, and that we weren't interested in when people with diabetes get COVID, what happens. We know that we have 228 systematic reviews of that. I don't need to be the 229th. We were interested in outside of infection, what was happening in this space. We designed and agreed our protocol. So this is a way of saying this is what we're going to set out to do before we do it with the World Health Organization, because we knew this was not the most straightforward question that had ever been asked, and we wanted to make sure that what we delivered to them was what they were expecting. We searched databases up to June 2023, and we used a framework called PICO to define our inclusion criteria. And this is actually what we did before we did anything else with the WHO. We said, can we just agree on what sorts of studies we might be looking at? And for those of you in the room who might be doing systematic reviews next semester, I would really encourage you to give a lot of thought to this component of your review. So what are you going to be looking at and what studies? And everything else can come from there. So here we were interested in people diagnosed with any type of diabetes, but not including pre-diabetes. We were interested in COVID-19 associated prevention measures, so that's the E in PICO, comparing either to pre or post-lockdown periods. And the outcomes we were interested in were those that WHO specified. We did a lot of back and forth here because we were interested in some other outcomes. I was particularly interested in outcomes of like quality of life and mental health, diabetes related to stress. They were like, nope, that's not what we want from you. We want clinical endpoints, is how they described it at the time. So what we ended up looking at were mortality, hospital admissions, something called diabetic ketoacidosis, which is more commonly known as DKA, and that's something that can happen if your blood sugars get dangerously high, and it's a life-threatening emergency. Amputations and sight loss, which are both complications of diabetes, emergency admissions, but also presentations, another complication of diabetes, severe hypoglycemic events, and that means when your blood sugar goes so low that you need medical intervention to help you. That again can be a medical emergency, and renal failure, which is another complication of diabetes. Because these data were so different, the ways the studies conducted themselves, the people they collected data from, and the way they reported their outcomes were all wildly different. We couldn't do a nice forest plot. So there was no statistical synthesis here because it just would have been very misleading. We weren't comparing like with like across these studies. And instead what we used was something that is known as effect direction plots or association direction plots, which sounds fancy, but means a table with arrows in it. And I will show you that in a second. And also as part of this, we assessed the quality of our studies using two different tools. One was called the Newcastle-Ottawa scale, and that's what we used for our observational studies, so for the primary literature, and something called the AMSTAR2 checklist for our systematic reviews. So here is an example of an association direction plot. We have these for all of our outcomes, and I won't go through all of them. But in this case, these are the studies that looked at diabetes-related mortality during compared to prior to the COVID-19 pandemic. And what that outcome means is people who have listed on their death certificate that they died because of their diabetes. How well this is recorded is somewhat up in the air. We were interested in this because one of the first stories that came out in England around the possible impact of disruptions to healthcare was actually around a surge in diabetes-related deaths outside of COVID infection that happened in the first half of April 2020. It was really marked. And people thought, okay, are we now seeing what happens when people can't access healthcare? And it turns out, yes, it looks like we were, because every row here is an included study in our review. The NOS is the score that we gave that study in our quality assessment. The higher, the better. We have data on which country, which are mainly here, Mexico, USA. In fact, Mexico and USA dominate this. All of our studies showed an increase in diabetes-related mortality during the pandemic compared to prior to the pandemic. So really consistent data there that more people were dying of diabetes during lockdown periods, essentially, than they were prior to that. When we looked at emergency hospital admissions in people with diabetes, I wanted to show this example because here the data is more mixed. So again, we have a bunch of different studies, mainly dominated here by the USA, Italy, and Canada. And we see different things. So in 2 of these studies, there's no indication of any difference in emergency hospital admissions in people with diabetes. In 3 studies, we see increases during compared to prior to the pandemic. And in 4, we see decreases. And this is an interesting thing to try and unpick. We can speculate as to why this is. We don't know for sure. People who found increases wrote that, of course, they'd expect to find increases because people's diabetes wasn't being as well managed, and therefore they were showing up in emergency rooms. People who found decreases said, well, of course, we'd expect to find decreases because people are scared of going to the hospital. They don't want to contract COVID. In England, there was a lot of messaging about not being a burden on the National Healthcare Service. This was messaging that got drilled into us a lot. So not only were you like, oh, do I go to the hospital? I don't want to get COVID, but you're also like, there's probably someone sicker than me, and I'm going to destroy the NHS by showing up with whatever concern I have. So that's what those plots look like. And what we did overall is draw these all together in a figure to represent the impacts on each of our outcomes. And that's what I'm going to talk you through as the last part of this review. So this particular figure needs a little bit of orientation. But basically what you have listed is each of our outcomes of interest, those clinical endpoints that WHO wanted us to cover. On the left and in blue are this number of studies that showed a decrease during the pandemic compared to prior to the pandemic. In the middle are those that showed no difference. And on the right in red are those studies that showed an increase during the pandemic compared with prior. So as we saw in terms of mortality, all-cause and diabetes-related mortality, most studies showed an increase in these outcomes. We saw a decrease in all-cause hospital admissions, and that probably is due to a mix of things. It is partly that some people were probably more protected and could manage their diabetes a little bit better without all of the chaos, but it is definitely also linked to the fact that people weren't showing up to hospital. You know, we had a lot of data in England that showed that if you looked at the face of it, basically people stopped having heart attacks in 2020. That's not what happened. It's just that people stopped going to the hospital with heart attacks. They were dying at home and it wasn't being investigated. So a lot of things going on there. When we drill into the diabetes-related hospital admissions, we saw some patterns in the data. So though a lot of studies showed decreases, a pretty similar amount showed increases. And when you tried to pick those apart, it turns out most of those studies were the ones that focused on pediatric ICU admissions. And this was kind of a sobering thing from this study because of all the hospital admissions to be facing, a pediatric ICU one is a pretty miserable one. And the theory around this is that, again, because people didn't want to go to the doctors or weren't being seen regularly by the doctors, by the time they were sick, they were really, really sick. With type 1 diabetes, not always, but you tend to be diagnosed in childhood. And it's a disease with a pretty slow onset. So like in my case, I was tired, I was thirsty, I lost a bit more weight than usual, but none of those things were kind of noticeable at the time. No one seemed concerned about them. I went for my yearly well child check at the UMass Medical Services. They ran their normal tests and were like, oh, you have a bit more sugar in you than we think you did, and read some more tests. And then they were like, oh, you have type 1 diabetes. This is what you need to do. And it meant at no point was there an emergency. But if that had happened during COVID, it would not have been picked up. And it wouldn't have been until I was really, really sick that I ended up in hospital. So that's probably why we're seeing that increase in those pediatric ICU admissions. No clear difference, but very little data on those severe hypoglycemic or low blood sugar events. Slight increase in amputations and slight increase in sight loss overall, and those are not necessarily surprising. The great things about diabetes complications is if you catch them early, they can usually be treated before you lose sight or before amputations. But if you're not going to your regular foot checks, if you're not going to your regular eye screening, by the time you show up with problems, it can be too late. No real difference in diabetic foot ulcer presentations that we could see. And when it came to diabetic ketoacidosis, so that's that really high blood sugar, that's a medical emergency, very different picture when we looked at adult and mixed samples compared to children. So again, a sobering picture in kids. And most of that seems to be driven by cases of new onset type 1 diabetes. So just like with those pediatric ICU admissions, kids who would have been picked up during routine screenings or who would have been picked up because their parents were a little bit worried and took them to the doctor. Parents who were a little bit worried during the pandemic did not take their kids to the doctor very much. And so you see there's some really clear outcomes, and those can have really profound impacts, obviously, on long-term health and well-being. And in this country and in other countries that don't have national health care, long-term financial impacts on families as well, to not catch it until it's that far down the line. I'd like to say that the information we found on difficulty accessing insulin was only in specific countries and only in specific settings. It's worth saying that that one study that highlighted it previously was in Bangladesh, but in reality, we know in this country as well, people really struggled to access insulin before the pandemic, and we absolutely know based on a lot of surveys, the pandemic made that worse for a lot of people. There was more and more insulin rationing that was happening as people's income was restricted, as people's health insurance was restricted, and also just a lot of people reported being scared of going to the doctor, of trying to get their prescriptions, of going to the pharmacy. And we know that that can have really disastrous consequences as well. So that's all the kind of like data stuff. But we felt that all of this painted a pretty bleak picture, but also a very number heavy picture. And when we were speaking to people about this who had lived experience with diabetes, they had so much more to say than could possibly be captured in these systematic reviews. And so a group of us, which included researchers, clinicians, and artists, got together and got some funding from the University of Oxford to do a public engagement with research project, which was an interactive artwork project where we invited people with diabetes to submit artwork in any form. It could be poems, it could be written narratives, it could be paintings about their experiences of living with diabetes during the pandemic. 26 people submitted their projects. We didn't collect a lot of data on them because we wanted to make sure they felt that they could remain anonymous, and within a couple weeks of launching it, about 800 people visited our digital exhibition. We had big plans that we were going to display this artwork physically in the Big Diabetes Center in Oxford, where people went for treatment. And at the time I left Oxford, they were still not doing in-person appointments since the pandemic. So they had moved to telehealth only. So it's living somewhere else at the moment, but one day, if they ever start welcoming patients through their doors again, we hope that this might be there to greet them. And I just wanted to share a couple examples of that. So on the left here is a painting that was submitted by an undergraduate university student who was living with type 1 diabetes. That thing on her arm is her insulin pump. And in the UK and in many places, there was a narrative at the start of the pandemic about like, can't the vulnerable just isolate themselves? Can't they just shut themselves away and the rest of us can live our lives? And I think particularly for young people, and Katie said in her explanation of her artwork, this was the case for her, a lot of her friends were saying this, and people didn't actually think of Katie herself as vulnerable. And she said that put her in a really difficult position when she was hearing this language. She was like, should my friends just go on and party and I shut myself away? Like, how do we deal with this? The second image here is a lino print from a parent of a child with type 1 diabetes. And I think there was one of the things that came through in this artwork project was a lot of anxiety from parents living with kids who had conditions that might make them more vulnerable to risk from COVID. And this, when they described this artwork, was really about the hope of a vaccine and the hope that that vaccine would unlock their family. It would let them outside again. It would let them start engaging with the world again. This was a poem that was submitted anonymously. Who are you to call me vulnerable? White coats with clipboards, computer algorithms, all with that word that smear diabetic. All my life I'm told you are vulnerable. You will most certainly get gum disease, kidney failure, have a stroke, go blind, lose a foot, a leg. The irony is it will be none of those things that get me. It will be my mind I lose, not a toe. It will be a heart attack one sunny day from all the years of suffering, the endless scaremongering, alarmism, obsessive name calling, diabetic, diabetic, diabetic. And we particularly found this really interesting to think about because I was personally kind of happy to be labeled as vulnerable because it meant I got higher up on the list to get my shot. I was like, sign me up, call me whatever you want. But obviously a lot of other people experienced that in very different ways. And all of a sudden we were being grouped into these groups of people who were and were not vulnerable to illnesses based on our underlying conditions. And I think a lot of people spoke to that being quite a scary and isolating and shaming experience for them. Partly because of this, I felt like we were putting out all this data that was really awful. It was being like, yep, you're at way higher risk of COVID, all these awful things might happen to you. And so we wanted to make sure that in the space that we could and with the control we had, we controlled the narrative somewhat and approached it with some empathy. So I wrote an article when the WHO stuff came out about understanding the different risks of coronavirus with diabetes, and that got published in something called The Conversation, which then gets republished in newspapers. And that was really nice because I tried to basically put things in perspective. I wanted to give people information, but also didn't want to be super alarmist. We worked with Diabetes UK, which I found really useful because they had direct access to patients and healthcare providers in terms of how we communicated about risks in people with diabetes. And our artwork, though it is still not in the Diabetes Center, is now being displayed at the History of Science Museum in Oxford. They've done a collecting COVID exhibit, which is what in my history master's mindset we would call very progressivist, and positivist. So it's all about them developing the vaccine, basically. And it's like, oh, these scientists came together and saved the world with this wonderful thing, and everything went really smoothly, which is also very exciting and a massive big deal and hugely wonderful. But it made us very happy to see this go in too, because it reflected some of the lived experiences of people in the community in England at the time, and not just that of the people who were developing these awesome vaccines. So yeah, that's been really nice. And it's been, I think, really nice for the people who submitted artwork that it's now on display in the museum. It's pretty cool. And I wanted to end on this hopeful note. So one of the people who helped us with our artwork project and also advised us on our reviews was someone who was a retired teacher who was living with diabetes. And she wrote an article about her experience of it. She had found the COVID pandemic really difficult and really alarming. And she wrote, I liked the idea that this project gave people living with or affected by diabetes a voice and a platform on which to share their lived experience. Health research is not just about the clinical, it's also about recognizing, empathizing with, and learning from the experiences of people as demonstrated in this project. For me, patient involvement in health research is about helping to bring about progress, is about learning more about one's own health and well-being, and also about giving something back. Above all, it is about hope. And I think that was really encouraging to hear. And for us who were kind of just trolling through many terribly written papers and then summarizing them and putting them out in academic journals, it added a real dimension of understanding, and I think also motivated us to do better in our research, to do this work alongside it. And just to say, in terms of my timeline, I don't know what's next. I want to do something more in this space. I particularly, the two things I'm really interested in are what does it mean to be labeled as vulnerable? And what do we need to think about when we're creating these frameworks of risk and then applying them to people? How does it feel to be applied? But also I would love to do more on access to insulin. And that's it for me. There's a happier boat picture to end the talk. Thank you. really happy to take any questions.
I have several, but I don't want to. So, what from your experience and the goal that drove you into this in the first place, this desire to impact health and people, what was your most positive takeaway and your most frustrating takeaway?
That's a good question. I think the most positive takeaways were seeing the work being cited in policy guidelines. So that first article we did, even in the summer, the UK put together this pretty bleak report called Preparing for a Difficult Winter, right? Which was like, it's going to be bad. And it was bad. But what came into that was some of those things around considering that actually people, especially with diabetes, do still need access to the healthcare providers, even if it's telehealth, and some very simple recommendations, which sound obvious, but in reality, were not going to be implemented around longer prescription durations. So normally you'd get a prescription that would last you a month in England. And what they did is they moved to 3-month prescriptions for things like diabetes because of concerns about people accessing their insulin and getting to the pharmacy. So that sort of thing, like someone sent me that report and was like, look, do you know that you guys are in it? And that was awesome. I was so excited. So that's a really positive take home. If you do relevant research and you talk about it, often it gets used, and that's amazing. I'd say some of the bigger frustrations were around working with our policy partners who didn't necessarily have the same exact interests that we did, right? And though they pressured us to produce things really quickly, it would then sit on their desks sometimes for months. And you just had to take some deep breaths around that.
Can you elaborate? What was the policy side of things that led to that kind of delay in implementation?
It was nothing interesting in that, like, one of the things you deal with World Health Organization is that they're all very siloed and no one talks to each other. So there was a little bit of an argument over whether or not the WHO Europe office was in charge of the diabetes COVID response, or if it was the WHO central office. So there was some power struggle around who signed off the thing. Once it was decided who signed it off, that person got long COVID, and there was no one else who could sign it off. That was another thing. Then there were concerns about declarations of interest from some of the people who had helped on the review. So all of that sort of thing. And actually, I should say one of the other really positive things was that before this, I had not worked with undergraduate students doing reviews. And in the UK, you do if you want to be a doctor, you do your medical degree as an undergraduate, and it's a 4 or 5 year course. And the 4th and 5th year, you're pretty much exclusively in hospitals. And all of a sudden, they were all told they couldn't come into the hospitals. So we had all these medical students who had quite a lot of skills and knowledge and nothing to do. And they were brilliant at helping get these reviews done. And for them, I think, for a lot of them, it resulted in publications that they could put on their CV, and it was a learning opportunity. And some of them really took the lead. And that was really exciting and fun too. Yeah.
Nice.
I think Liz asked a question in the chat.
Let me see if I stop sharing, because I can't see the chat at all right now. Here we go. Liz said, I enjoyed seeing how you integrate the arts with public health research. Thank you. Can you share how the arts are being integrated into your current or upcoming work, and what you expect will be some pros and cons of doing that? That is a great question. Hi, Liz. I'm trying to figure that out at the moment. So my upcoming work, or my current work at the moment, is all around tobacco and e-cigarettes for the most part. And there are some specific sensitivities to how those things get communicated. So that songwriting example that Brian touched upon was a song that we wrote and performed as part of this like EU-funded carnival around people who smoke, encouraging them to consider switching to e-cigarettes. there are certain groups where if I played that song, people would be very, very upset. And so one of the things I have to figure out now I'm here is how to disseminate in a way that my funders will be happy with and won't like ruffle feathers too much, but will still feel exciting to me. So Liz, the short answer is I don't know. But it's been so rewarding. We love doing it so much that I can't imagine doing anything that doesn't have some degree of this, even if it's just writing about it in pieces that are accessible.
Yeah, that's great. I can share we developed a course like public health and the arts that will be offered next spring, not this spring, but next spring. So might be tapping you to be a speaker.
Oh, awesome. I'd love to.
Yeah, very cool. We can talk more.
Okay.
Thanks.
I want to ask you one more question. Similar format of the last question, but now based on your experience with synthesizing evidence, where you're working by not conducting studies, but rather looking at other research that's been done and trying to benefit from it, but without amplifying garbage.
Yes.
So based on this tool, and a tool that I think a lot of students will maybe have as part of their studies to learn about a topic, what are the things that you think are the greatest strengths and the greatest challenges in working in that space?
Okay. As in like in the evidence synthesis systematic review space. So I think there are many. I love systematic reviews, which most people don't, but I am a real geek. So I just enjoy them for the process of going through and categorizing and understanding. But I think there are real strengths in when you do a systematic review, you become an expert in that area because you've read all the literature on it. So you all of a sudden become someone who knows so much about a specific topic. And one of the nice things in systematic reviews is that they can go on to inform policy, but they can also go on to inform future research. And a big thing we try and focus on is any systematic review will always say there needs to be more research. That is like a given. But the specific research, sometimes people don't really specify. And so what we try and say is there need to be more studies that are conducted in this way and look at this, this, and this. And the amazing thing about doing repeated systematic reviews in the same area is that then those studies often get done and they'll like cite you in the introduction. They'll be like, Hartmann Boyce et al. Said we needed a study like this, and here it is. So that's incredibly rewarding. And just seeing them be used and get all of this noise into something that is cleaner and can be communicated more clearly is really, really rewarding. The downsides are that you lose a lot of faith in the scientific process because you read so many poorly written articles and you think, how did this get published? Like the number of mistakes you find when you read papers is quite amazing. So I think the upside is that it hones critical appraisal skills, but it is a real challenge. And there are tools out there that help you think through in a systematic way, how much do I trust what I'm reading? And I think those skills are so useful even beyond systematic reviewing.
Yeah, that's great. And I think this is something that's super accessible for students to both do the reading and also participate in, because you don't need a boatload of money or time to conduct research, and you can rapidly become, relatively speaking, an expert in a field. And also a little bit of this sobering lesson that science, for all of the lofty ideas we have about it, it's still a human enterprise.
Exactly.
And make mistakes.
Exactly.
Well, this has been really great. Thank you so much for this.